management that is available. The role of medical therapy in these cases often just supportive, and the most definitive role is of surgical therapy. I have no financial disclosure on any of the products that we mentioned during this presentation. We'll be speaking about a few things about the acute stage management in terms of the medical management, the role of medical therapy in the chronic phase, and also the role of medical therapy in the end-stage disorders as to what, when, and how long should the medical therapy last. We're doing a few case scenarios, such as in this case of a 20-year-old male who had a history of chemical injury a day back and was given saline wash. He was on therapy with lubrication, steroids, and cycloplegic. Compared to this, another scenario wherein a 37-year-old female who had a history of chemical injury 4 years back, which was left untreated in the acute phase, developed a right eye total limbal stem cell deficiency with lower limb secretory entropion and a synuclein, and a left eye partial limbal stem cell deficiency. Going to another case scenario of a 13-year-old female with a history of antibiotic therapy given for fever, which was a week back. On day 3 of antibiotic therapy, she developed blisters all over the body, mouth, and redness of both eyes, and the diagnosis of acute SJS. Another scenario of a patient having a chronic SJS with severe dry eye and keratinization of blood margin and vascularized corneal opacity in the other eye. When you look at all these different case scenarios, what you realize is there's a common baseline to all of them, whether they are in the acute phase or in the chronic phase. And this common baseline is that of inflammation. In order to achieve a good and a normal ocular surface, what we need to do is to tackle this inflammation and hit the inflammation at its every stage of the disease process, whether it's in the acute phase or in the chronic phase, in order to have a healthy ocular surface. The most important thing is to deal with these patients in the acute phase when they present in the early phase of disease. Be very aggressive with your management protocols. It's important to be preventing any chronic complications of these disorders in order to, rather than sitting and curing them in the chronic phase. In the acute phase, whatever management you do is going to really prevent the blinding complications, especially in case of chemical injury and Stevens-Johnson syndrome. The most important therapy is topical corticosteroids in these cases. Despite having an epithelial defect, unlike our traditional learning wherein we say whenever a cornea has an epithelial defect, we really would want to refrain the patient from getting topical steroids. But in cases of chemical injury, the most important therapy is steroids, and steroids. Topical lubrications in terms like tear substitutes, especially preservative, three because they have to be given almost every half hourly to 1 hourly in these cases. Topical antibiotics as prophylaxis against any secondary infection and cycloplegic, and topical anti-glaucoma medication as and when required. In the acute phase of Stevens-Johnson syndrome, the patient will require intensive steroid therapy with intravenous methylprednisolone with 500 to 1000 milligram in 3 doses, IV immunoglobulins, topical cyclosporin 0.5%, topical antibiotics, topical steroids, and lubrication. In the chronic phase, when you're dealing with medical management, the management is essentially to protect the ocular surface in order to support the ocular surface, to reconstruct and maintain the ocular surface. Ocular surface protection is essentially with the gamut of lubrication that are available. The preferred ones will be preservative-free lubrication. In order to protect the ocular surface, what you may have to sort on to give along with lubrication, also to give them scleral contact lens. I'll be coming in the later part of the presentation and explaining about the various types of scleral lenses. And for support of the ocular surface, we have modalities like ocular serum or transretinoic acid, cyclosporin, oral tetracycline, topical and oral corticosteroids, and surgical therapy. Autologous serum essentially acts by providing a lot of surface protective agents in the form of lactoferrin, lysozyme, vitamin A, epithelial growth factors, and various other immunoglobulins which are required in order to protect the ocular surface. The important thing is to prevent the cytokine activation and also to have a tear film stabilization, which would really help you in ocular surface diseases and also improve the patient comfort level. All transretinoic acid is usually available as an ointment, not easily commercially available. It improves the conjunctival squamous metaplasia and all, but the only important thing is this leads to a lot of peripheral conjunctivitis. Cyclosporin acts by inhibiting the T-cell mediated cytokine production and in turn decreases inflammation. Cyclosporin may be given as 0.05 to 2%, 2 to 4 times a day, and a long-term therapy is required in most of these cases. Oral tetracycline also act as surface protecting agents, and they may be given over a long period, that as low doses as 20 milligrams a day to be continued for a long time. Along with the antibacterial property, they also have anti-inflammatory and anti-angiogenic property. Omega-3 fatty acids along with omega-6 fatty acids have now been proved to be anti-inflammatory, and which block the gene expression of the pro-inflammatory cytokines and are just protecting the ocular surface. A low dose of steroid therapy has to be maintained on a chronic phase in most of these patients in order to decrease the inflammation that they have. Notocriminol etabolate 0.2 to 0.5% may be required in most of these cases. The patient in the acute phase may be started with oral steroids as high as 1 to 1.5 milligram per kg, which have to be slowly tapered in the chronic phase, and later on the patient may be required to be maintained on a very low dose of steroids. Ocular surface reconstruction will be dealt in detail in the previous presentation and also in the next presentation by Dr. Rao. You have to maintain the ocular surface, and in that you may have to go in for a step-ladder approach in order to decrease the inflammation, and may have to swap into immunosuppressive therapy. For very mild inflammation, you may just give the patient methotrexate or naloxone. When the inflammation increases, you may have to go a step up or a step down ladder along with this kind of a protocol. When you start with methotrexate, in case of very severe inflammation, you may also have to resort to higher immunosuppressive agents as azathioprine or mycophenolate, or sometimes even cyclophosphamide. In acute intermittent cases, you may also require to give them high pulse doses of steroids intermittently, as well as intravenous cyclophosphamide whenever the patient is having acute inflammations. Especially when you're contemplating any surgeries in the acute post-operative period, also they may be required to be given pulse steroids and pulse immunosuppressive agents. There are different protocols that are for non-pemphigoid associated and pemphigoid association inflammations in these cases. So, how the immunosuppressive agents work is by decreasing the inflammation at various levels in the immunological cascade. Most important thing is when you're having these patients on immunosuppressive therapy is to monitor them regularly for their enzyme levels, as a liver function, the renal function. It is also important to counsel the patient about the cost factor that is required with this immunosuppressive therapy. Most of these therapies are costly. The cheapest being the methotrexate, which has to be given only once a week dosage, comes to almost only 12 rupees per week. To costlier agents such as cyclosporin, where the patient has to shell out almost 200 rupees per day. Most important and the last but not least important thing is to give a psychological therapy, because these patients would require to be on a chronic follow-up with you. There is always a patient and the family counseling that is required in these cases in order to motivate them for having a regular follow-up, because these patients are going to be your patients for lifelong. Thank you.